Hey guys, welcome back to my channel, The ENT Resident. Today I'll be discussing a topic in otology, and that is labyrinthitis. Now, usually we learn about labyrinthitis as a complication of CSOM. There are three different types to it. We'll be discussing each one of those types. So, before we get started, I also wanted to tell you that you can also now purchase my notes. I have added the links in the description. Okay, so let's get started with labyrinthitis. The three different types are: first is circumscribed labyrinthitis, also known as labyrinthine fistula. Now, we'll cover labyrinthine fistula in a separate video. The two types that I'll be discussing today are diffuse serous labyrinthitis and diffuse suppurative or purulent labyrinthitis. Now, let's start with diffuse serous labyrinthitis. What is this exactly? Now, diffuse serous labyrinthitis is defined as a diffuse intralabyrinthine inflammation without the formation of pus, and this condition is usually a reversible condition if you are able to treat it early. And if you are able to treat it early, diagnose and treat it early before the development of suppurative labyrinthitis, the prognosis of this type is actually very excellent. In this type, the whatever hearing and vestibular dysfunction happens is entirely reversible with the right treatment. And here, perilymph is involved, but not the endolymph. So, what are the possible causes of diffuse serous labyrinthitis? The most common cause over here is a pre existing labyrinthine fistula, which could be associated with CSOM or cholesteatoma. This is the most common cause of diffuse serous labyrinthitis. Other than that, it can also occur because of acute otitis media and mastoiditis, where what happens is the bacterial or the viral toxin that gets released, it invades through the round or oval window to involve the labyrinth. That's when it causes a diffuse serous labyrinthitis. Other less common causes are meningeal inflammation and certain ear surgeries like fenestration operation or stapedectomy. Now, what do you see? What does the what does the patient present to you with? So, first of all, a case of spontaneous vertigo in a case of middle ear infection should indicate to you that this is a case of serous labyrinthitis. So, whenever there is a case of otitis media, whether it is acute otitis media or chronic otitis media, whenever that case develops vertigo, you should definitely suspect serous labyrinthitis. Now, the vertigo that we see over here is definitely more severe than a case of labyrinthine fistula, but it is less severe than a case of diffuse suppurative labyrinthitis. So, this is on a spectrum from labyrinthine fistula to diffuse serous to diffuse purulent labyrinthitis. This vertigo in this case lies somewhere in middle, and the vertigo will be associated with nausea as well as vomiting. So, this is the prime clinical feature or symptom that you see in this patient. Other than this, you will also see a irritative type of nystagmus. Now, what does irritative type of nystagmus mean? Here, what happens is the quick component of the nystagmus will be directed towards the diseased ear. There is another type of nystagmus, which is the paralytic type of nystagmus, which we will be seeing in diffuse suppurative labyrinthitis. Third, if this case has happened secondary to the development of a labyrinthine fistula, in that case, you will see that on performing fistula test, it will be positive. Fourth, there will be a mild sensory neural hearing loss, which will be reversible in nature. And caloric tests will show diminished vestibular response. But if you're not able to diagnose a case of serous labyrinthitis early and treat it properly, it may pass into forming suppurative labyrinthitis. And when that happens, this becomes a irreversible condition. And here we'll end up seeing a total loss of vestibular and cochlear functions. So, serous labyrinthitis is a very treatable, very reversible condition that you see. And if you are able to diagnose it early, the prognosis is excellent. But if it gets further complicated and develops into suppurative labyrinthitis, then you are left with complications. So now that we know about the features, how are we going to treat the disease? So first of all, we have to do an active and prompt treatment so as to prevent the development of suppurative labyrinthitis and prevent any permanent and complete damage to the labyrinth, and also prevent the spread to meninges. So, what we'll do here is, first of all, the patient will be advised to be in bed with their head immobilized and the affected ear pointed above. We'll give IV antibiotics to control the infection in the middle ear and the labyrinth. Third, we'll give labyrinthine sedatives for helping in symptomatic relief of the vertigo. Now, the usual sedatives that are given are prochlorperazine or dimenhydrinate. Myringotomy is performed if the labyrinthitis has followed a case of acute otitis media and we are seeing that the tympanic membrane is bulging. In that case, we'll perform a myringotomy and chrome insertion if required. Last method over here would be a surgical treatment where we'll perform a cortical mastoidectomy in case of acute mastoiditis or a modified radical mastoidectomy in a case of cholesteatoma. However, before you perform any surgical intervention, it is important that you first give medical treatment and try to treat the disease just using medicine. Only when medical treatment has failed do you prefer to use a surgical treatment over here. So, this is about diffuse serous labyrinthitis. Next, let's talk about diffuse purulent labyrinthitis. So, this is the more severe type of labyrinthitis that we know. So, this is actually defined as a diffuse pyogenic infection of the labyrinth with a permanent loss of vestibular and cochlear functions. This is a irreversible condition. The cause of diffuse purulent labyrinthitis is that it usually follows serous labyrinthitis when pyogenic organisms entered through a pathological or a surgical fistula, usually associated with cholesteatoma cases or acute otitis media, even meningitis. There are certain predisposing factors for diffuse purulent labyrinthitis. These are Mondini's deformity, enlarged vestibular aqueduct, Stapes surgery, dehiscent internal auditory canal opening, patent cochlear aqueduct, and labyrinthine fistula. So, all of these conditions, if present, are actually risk factors for development of diffuse purulent labyrinthitis. Now, what are the routes of infection in this case? One, the most common one, is that it can be a tympanogenic route. The causes here would be otitis media, mastoiditis, petrositis, temporal bone fracture, penetrating injuries, middle ear surgery, and even tumors. Second is a meningogenic route, where the common cause is basically meningitis. However, this is rarely seen. The more common cause and route of infection is tympanogenic route. Last of all, the third one is a hematogenic route, where it can spread from a systemic infection or from adjacent areas such as meningitis, encephalitis, or even a brain abscess. Now, what are the features you will be seeing in this patient? So, diffuse purulent labyrinthitis has three stages: acute stage, chronic stage, and a healed stage. So, first, let's talk about the acute stage. The acute stage is usually the first 1 to 2 weeks. Here, what we see is a rapid onset of tinnitus, vertigo, pallor, sweating, nausea, and vomiting. Usually starts within half an hour to 1 hour. These symptoms are usually very unrelenting and they do not respond. Most likely, they're not going to respond to any treatment for 8 to 12 hours. Now, the dizziness that the patient is complaining of will eventually improve over the next few days. But any kind of head motion will end up in evoking severe vertigo and nausea, vomiting. Then, next, what happens is there is a central nervous system compensation which happens over the next 2 to 3 weeks. Now, let's talk about what is the nystagmus that we'll see here. The nystagmus we see here is a brisk, jerky nystagmus. So, first, we'll see an irritative type of nystagmus where the quick component will be directed towards the affected site on the first day. Later, this nystagmus becomes a paralytic type of nystagmus where the quick component is towards the opposite side or the healthy side. Now, the vestibular symptoms that you're seeing that persist for the first couple of days, they usually start to subside after about a week. The patient lies quietly on the affected ear and they are not able to stand or sit. And any kind of slight head movements also will cause vertigo and nausea, vomiting. You can also see complete hearing, sensory neural hearing loss over here, past pointing, and a tendency to fall towards the diseased side. And it has been seen that usually unilateral cases seem to produce more severe vestibular upset than bilateral cases. Unilateral cases usually happen after CSOM, cholesteatoma, acute otitis media, whereas bilateral cases usually happen after maybe a case of meningitis. So these are the features that you're seeing in the acute stage of diffuse purulent labyrinthitis. Next comes the chronic stage, which is also known as the latent or the fibrous stage. This can last between 1 to 6 weeks. In this stage, there is usually a milder vestibular upset and some positional vertigo. There is absence of both cochlear and vestibular functions, and bilateral lesions here lead to difficulty in walking, especially in the dark or on a soft surface. That brings us to the last stage, which is the healed stage, also known as the compensated or ossification stage. At this stage, it is known as labyrinthitis ossificans. Here, what happens is the formation of new bone occurs over a period of several months. Many years are required to end up at this healed stage. So, these are the three stages of diffuse purulent labyrinthitis and the different clinical features that you see in such a patient. Now, the treatment of this case will be the same as in serous labyrinthitis. The only other thing that you have to keep in mind is sometimes, very rarely, you may need to do a drainage of the labyrinth if the intralabyrinthine suppuration is acting as a source of any kind of intracranial complication. So that's all about labyrinthitis. If you have any question, please note them down in the comment section and I'll get back to you. Thank you.